Hey there, and welcome back to the Deep Dive.
Hello.
Today we're diving into urinary incontinence. We've got a stack of revision notes here, and our plan is to unpack them for you.
Yeah, make them really accessible, high yield, useful if you're revising.
Exactly. We're sticking strictly to these notes, what it is, causes, risks, how it works, what else it could be.
Who gets it, how it looks, investigating it, managing it, the long-term view, and potential problems too,
Well,
all based on this material.
it's a really important topic. It affects a lot of people, more than you might think.
It really does. And understanding the basics, the core concepts from these notes is key.
Okay, let's unpack this, starting right at the beginning. What is urinary incontinence?
So the basic definition is pretty straightforward. It's the involuntary loss of urine. Simple as that.
But it's not just one thing, right? The notes mention a range.
Exactly. It can be anything from, occasional little leaks when you cough or sneeze, right up to a complete loss of bladder control.
And the notes give a statistic early on
Mm.
about prevalence. They do. Around 4 to 5% of the general population, but significantly more common in older women. That's a key point.
Which leads us nicely into the different types. You mentioned this is crucial.
Absolutely vital, because the why it's happening
Yeah.
and the how you manage it really depend on the specific type. The notes lay out several main ones.
Okay, so first up is functional.
Right, functional. This isn't really a bladder problem itself. It's more about things like poor mobility or maybe cognitive issues, meaning someone just can't physically get to the loo in time.
Got it. Then stress incontinence. That sounds familiar.
Very common. That's the leakage that happens with effort or exertion,
Yeah.
coughing, sneezing, laughing, lifting heavy things, anything that puts pressure on the bladder.
Okay, an urge.
Urge is that sudden, really intense feeling that you have to go, like, right now. And it's often impossible to hold on, leading to leakage, sometimes called an overactive bladder.
And you can have both.
Yep, that's
Mhm.
mixed incontinence, a combination of stress and urge symptoms, very common too.
The notes also list overactive bladder syndrome. Is that the same as urge?
It's related. OEB is defined by urinary urgency, often with frequency needing to go a lot and nocturia, waking up at night to pee. It can include urge incontinence, but doesn't always have to involve leakage.
Ah, okay. Subtle difference. What else?
There's overflow incontinence. This happens when the bladder doesn't empty properly, maybe due to an obstruction, like an enlarged prostate in men. It gets too full and the urine sort of spills out.
Like a dripping tap.
Kind of, yeah.
Yeah.
And finally, the notes mention true incontinence.
True.
Yeah, described as continuous leakage, usually linked to an anatomical issue, like a fistula, an abnormal connection.
Wow, okay. So a fair few distinct types there. Identifying which one is the first step.
Definitely. According to these notes, that's your starting point.
So once you've got an idea of the type, you look at the causes, the etiology.
Exactly. And the notes stress that causes are often type-specific, but there are some common themes. Things like weakened pelvic floor muscles.
Which links straight back to stress incontinence.
Right. Then issues with the bladder muscle itself. Maybe it's overactive, causing urgency, or maybe it's underactive, leading to poor emptying and overflow.
Okay, what else?
Hormonal changes are mentioned, especially around menopause in women. Neurological disorders are a big one, conditions affecting the nerve signals between the brain and the bladder.
Like Parkinson's or stroke?
Precisely. Infections, like UTIs, can cause temporary incontinence. Certain medications can contribute, and other underlying medical conditions too.
That makes sense. And this ties into the risk factors listed in the notes. Things that increase the likelihood.
Yes, there's a pretty comprehensive list. Advancing age is a major one. For women, pregnancy and childbirth are significant risks.
Especially certain types of delivery.
Yeah, the notes mention vaginal delivery, forceps use, having larger babies. Those increase the risk.
Obesity is on the list too. High BMI.
Yep, history of hysterectomy. Even a family history of incontinence.
Really? A genetic link?
Seems so. Diabetes is listed. And interestingly, the notes specifically point to oral estrogen therapy as a risk factor.
That is interesting. What else stood out?
Well, recurrent UTIs, especially in women. For men, having lower urinary tract symptoms, or LUPS. Infections in men, too.
And things affecting function.
Absolutely. Any functional or cognitive impairment, think stroke, dementia, Parkinson's again, these can directly lead to functional incontinence.
What about surgical history?
Prostatectomy in men is a known risk, and any kind of blockage, like an enlarged prostate or pelvic tumors in women.
And the surprising one you mentioned.
Ah, yes, stool impaction,
Yeah.
especially in the elderly. A packed rectum can definitely affect bladder function, worth remembering for revision.
Definitely. So lots of factors, sometimes overlapping. Now, the pathophysiology, how does it actually happen in the body?
This section breaks down the mechanisms. So number one, weakened pelvic floor muscles. We've linked that to stress incontinence.
Okay.
Number two, overactive bladder muscles. That's your urge incontinence mechanism.
Right.
Third, impaired nerve signaling. Problems with the communication between the brain and bladder. That covers neurological causes.
Makes sense.
And fourth, actual anatomical abnormalities. Things like fistulas, leading to true incontinence.
So those are the core breakdowns leading to the symptoms. But sometimes incontinence symptoms might point to something else entirely, the differential diagnosis bit.
Exactly. What else could it be? The notes list, key things to consider. UTIs are a big one, the anemic incontinence symptoms,
Okay.
bladder or kidney stones,
Yeah.
and more seriously, bladder cancer needs to be on the radar.
Right, especially given the referral criteria later.
Absolutely. For men, prostate disorders are crucial differentials. And again, those underlying neurological conditions might be the primary issue or coexist.
Good to keep those alternatives in mind. Let's talk epidemiology. How common is this, particularly in the UK?
The notes estimate around 4 million people affected in the UK, so pretty common.
And it confirms it's more common in women and increases with age.
Yes, definitely. But the notes also highlight that getting exact numbers is tricky. There's variation in how it's defined in studies, and significantly, there's stigma. People often don't report it.
That study mentioned really drives home the stigma point, doesn't it?
It really does. Found that, 40% of women over 21 had experienced it sometimes, and for 8.5%, it was significant. Stress incontinence was the most common type they found.
But the key finding.
Only 17% sought help. Many just thought it was, a normal part of getting older, which is quite striking.
That's huge. Such a hidden issue. What about men?
Data is more variable for men, the notes say. Prevalence estimates range massively, like 5% up to over 35%, depending on the study. But the trend is the same. All types increase with age, and it's very common in institutionalized adults.
Okay. So if someone presents with these symptoms, what does the clinical presentation look like, and how does the assessment start?
Presentation really depends on the type. Stress, they'll tell you about leakage with coughing, sneezing, exercising. Urge. It's that sudden, desperate need to go, often with leakage before they make it.
Mixed is both. Overflow.
Overflow is often more like constant dribbling, maybe feeling like the bladder isn't fully empty, often linked to obstruction.
And function.
That's the story of not being able to get to the toilet because of other issues. Mobility problems, confusion from dementia or medication, maybe arthritis making it hard to manage clothing.
So the history is absolutely key to narrowing down the type. What specific questions do the notes say to ask?
Really thorough history needed. Pin down the type based on those symptom patterns. Ask about triggers, what makes it happen, frequency, severity, how much leakage, any neurological symptoms.
And for women, the obstetric history is vital.
Crucial. Number of pregnancies, deliveries, types of deliveries, baby weights. The notes recommend using a bladder diary, getting the patient to track fluid intake, when they pee, when they leak, for at least 3 days.
That gives objective information.
Exactly. Also ask about sexual function, check their current medications list. Remember, meds can be a cause. Bowel habits are important too. Think back to that stool impaction risk. And critically, ask what the patient wants. Are they seeking treatment?
Good point. What about the physical exam?
Also detailed in the notes. For women, assess pelvic floor muscle strength. Check for any pelvic organ prolapse. Look at vaginal health signs of atrophy, perhaps, plus general abdominal, pelvic, and neurological checks.
And for men?
Check the prostate via digital rectal exam for enlargement. Assess pelvic floor muscles too, and again, abdominal, pelvic, and neuro exams.
That thorough workup then guides the investigations. What's the typical path according to these notes?
Initial steps include that bladder diary we mentioned, 3+ days. A vaginal exam for women is key, assessing pelvic floor, prolapse, etc. Basic urine tests are standard. A urine dipstick first, then a culture if needed to rule out infection.
What about urodynamics?
They're listed initially, described as tests of bladder urethral function. But the notes clarify later they're often considered more specifically before surgery, not necessarily routinely up front for everyone.
Okay. What about tests done typically in primary care?
Urine dipstick is standard for both men and women, checking for blood, glucose, protein, signs of an infection like leukocytes, nitrites. Assessing post-void residual urine volume is important too.
How much is left after peeing?
Yeah. Especially if you suspect they're not emptying well or they get recurrent UTIs. Measuring urine flow rate is mentioned too. particularly for men or anyone with neurological issues, to check for obstruction or poor bladder function.
And importantly, what isn't usually needed right away?
Yes, this is high yield.
Yeah.
Cystoscopy of the camera into the bladder is specifically noted as not initially recommended for women with straightforward incontinence. Same for most imaging, like X-rays or CTs, not routine for women initially, though ultrasound for that residual volume is okay. Kidney ultrasound might be needed if there's no neurological disease.
That clarifies the typical pathway. Now, a really crucial section, when to refer straight to secondary care.
Absolutely critical for safety. The notes list emergent referral criteria. This is mainly about suspected cancer. So women with incontinence, PLOS, other features suggesting bladder or kidney cancer, and men who meet the criteria for that 2-week suspected cancer pathway referral.
So cancer suspicion, urgent referral. What about less urgent reasons to consider referring?
There's a list for consider referral. Things like persistent bladder or urethral pain, finding benign pelvic masses on exam, coexisting fecal incontinence, if you suspect a neurological disease is the main cause, significant difficulty emptying the bladder,
Okay.
suspected urogenital fistulae, if they've had previous continence surgery or pelvic cancer surgery or pelvic radiation, and for men, complicated LUTS symptoms.
That's a really helpful list for knowing when specialist input is needed. Right, let's get into management. The notes break it down by type again, starting with urge.
Urge incontinence, or OAB, first line, non-drug approach, bladder retraining. This means structured training, gradually increasing time between toilet visits. The notes say minimum 6 weeks trial.
And if that's not enough, medications.
First-line drugs listed are antimuscarinics. They help relax the bladder muscle, but they can have side effects like dry mouth.
Right.
So if those are a problem, mirabegron is listed as an alternative. Different mechanism, beta-3 agonist.
Okay. What about stress incontinence, the leakage on effort?
Mainstay non-drug treatment. Pelvic floor muscle exercises. Kegels. And the notes give specific instructions here, very useful for revision.
What were the numbers?
Aim for 8 contractions, done 3 times every day, and crucially, keep it up for at least 3 months to see the benefit. Consistency is key.
8 reps 3 times a day, 3 months. Got it. What if exercises aren't enough?
Surgical options are mentioned, specifically retropubic midurethral tape procedures as a common approach. If surgery isn't suitable or the patient declines, the medication diloxine is listed as an option.
And for mixed incontinence, bit of both.
Logically, you treat the predominant symptom first. Often it's a combination approach, pelvic floor exercises for the stress part, bladder training for the urge part. Medications like antimuscarinics might be added for the urge component. And the notes suggest annual reviews if someone's on long-term meds.
Makes sense. Overflow.
Overflow is all about tackling the underlying cause, usually obstruction. So treating that obstruction is key. This might involve intermittent self-catheterization to ensure the bladder empties, or a specific treatment if it's due to an enlarged prostate.
The notes had an other management section, too.
Yeah, covering other scenarios, like catheterization, intermittent self-cath, or indwelling catheters, noting suprapubic ones might have fewer issues than urethral ones long-term. For people with cognitive impairment, prompted or timed toileting can help. Bladder retraining is also mentioned for neurological disease.
Any more advanced options?
Yes, botulinum toxin A, injections into the bladder muscle for refractory overactive bladder. Augmentation cystoplasty surgery to enlarge the bladder for severe storage problems. And desmopressin for troublesome nocturia, but with cautions.
It mentioned things NICE doesn't recommend.
Right, important to know what's not advised to. And overall, follow-up and regular reviews are stressed.
That's a really thorough overview of the management toolkit, clearly tailored to the type. What about the prognosis, the outlook?
Depends heavily on the cause and the treatment, as you'd expect. But the notes emphasize that symptoms can often be managed effectively or at least significantly improved.
So often manageable, even if not always completely curable.
Exactly. With the right interventions and lifestyle changes, quality of life can often be much better.
And prevention, anything the notes mentioned there?
It's brief. Mentions earlier, NICE guidance suggested pelvic floor training during pregnancy preventatively, though later guidance is more targeted. Weight control is also mentioned as potentially reducing risk, especially for stress incontinence because of the pressure link.
Simple things, but potentially helpful. Lastly, the complications. What can happen if incontinence isn't managed?
Several things listed. Skin problems are common dermatitis, breakdown from constant moisture, big impact on quality of life, social isolation, embarrassment.
Yeah, you can see how that would happen.
And importantly, especially in older adults, It increases the risk of falls and fractures, often from rushing to the toilet, particularly at night.
So it's much more than just the inconvenience of leakage, real health consequences.
Absolutely. Which is why the notes stress that managing the incontinence is important to prevent these downstream issues.
Okay, I think we've covered all the key sections from these revision notes: definition, types, causes, risks, pathophysiology, differentials, epidemiology, presentation, assessment, investigations, referral criteria, detailed management by type, prognosis, prevention, and complications.
It's quite a journey through the topic, and what really stands out, I think, is how interconnected it all is. The type dictates the likely cause, which guides the investigation, which determines the management. It's all linked.
That's a great takeaway.
It raises that key question for you, listening and revising. Can you take a symptom, say, leakage on coughing, and trace it back? Think, okay, likely stress. What are the risks? Weak pelvic floor. Pathophysiology fits. Investigations needed. First-line management is pelvic floor exercises. Can you make those connections based on this material?
Excellent challenge. Well, that brings us to the end of this deep dive on urinary incontinence. Hope you found that useful for your revision. If you are studying for the MSRA or similar exams, getting this kind of focused breakdown can be really helpful.
Absolutely. And there are resources out there specifically designed for this. You should check out passthemsra.com.
That's passthemsra.com and also freemsra.com.
freemsra.com. Both have lots of great material.
Perfect. Thanks so much for joining us today.
My pleasure.
We'll catch you on the next deep dive.